Welcome to the Deep Dive. Today we're tackling a really significant topic, one that's key for medical revision, definitely, but also touches, so many people's lives. Infertility. We've got these MSRA revision notes in front of us, and they are packed. So our plan, our mission, if you like, is to dive right in, pull out all that high-yield stuff, and lay it out clearly for you, make it memorable. Basically the key revision facts, but in conversation form.
Absolutely. And understanding infertility is, well, it's vital. These notes, they point out straight away, it affects about 1 in 7 couples here in the UK.
Wow, 1 in 7.
Yeah, it's a lot.
A
So
lot.
you will encounter this. And beyond the medicine, there's this huge emotional aspect, social too. Getting the basics solid is, well, it's fundamental.
Exactly. So we're going to work through the notes systematically. Start with the definition, then look at why it happens, how we figure it out, the treatments, and then touch on things like prognosis and, importantly, complications, step by step. Okay, first things first then. Let's unpack this term infertility. What are we actually talking about here? What's the definition these notes give us?
Okay, so the notes are quite precise. They define it as the inability to conceive after 1 year of regular unprotected intercourse.
1 year. Okay.
But, and this is a key point, for women over 35, that time frame shortens. It's 6 months then.
Ah, right. 6 months over 35. Noted.
And it also covers the inability to actually carry a pregnancy to term. The notes also mention subfertility is often used interchangeably, and they give the WHO definition too, which is pretty much aligned failure to get pregnant, clinically pregnant, after 12 months of regular unprotected sex.
That age distinction, 35, definitely feels like a high-yield point for revision. And it's interesting, the notes follow that definition with some stats, that about 84% conceive within a year, 92% within 2 years. It kind of puts the definition in perspective, doesn't it? It's defined after that time period, not necessarily meaning it's permanent from day one.
Spot on. It's about hitting that point where investigation becomes appropriate, because for most, it does happen within that time frame.
So how common are we talking? You mentioned the UK stat earlier.
Yeah, it's that 1 in 7 couples figure for the UK, approximately. But it's worth remembering, the notes hint at this too, that prevalence can vary. Depends on age profiles in a population, lifestyle factors, underlying health stuff.
Right. Okay. And if someone is experiencing infertility, how does that usually present? What brings them to the doctor?
Well, the main thing, the core clinical presentation, is essentially what it says on the tin. The inability to conceive despite trying with regular unprotected sex.
Pretty straightforward then.
It is, fundamentally. Now, the notes do mention that sometimes, someone might have other symptoms linked to an underlying cause. Maybe their periods are all over the place, suggesting an ovulation issue, or perhaps pelvic pain, suggesting endometriosis. But the primary problem, the reason they've come in, is the lack of conception.
Okay, now for the really interesting part, the why, the etiology. What causes infertility? The notes break this down, right?
They do. They start broad grouping causes into, big buckets. Problems with the reproductive system itself, hormonal imbalances, genetic things, lifestyle factors, and other medical conditions impacting fertility. Then they give us some really useful percentages for the common culprits. And these are worth locking in. Male factors are a big slice, 30%.
Okay.
Then you've got unexplained infertility, that's 20%. Ovulation failure, another 20%. Tubal damage is 15%. And then other causes make up the last 15%.
That 30% for male factors really jumps out. It hammers home that this isn't, solely a female issue. Investigation has to involve both.
Absolutely critical point.
And unexplained at 20%, that's quite high too. Suggests sometimes we just don't have all the answers yet.
Exactly. Even with thorough checks, sometimes a clear cause isn't found. The notes also give slightly different figures specifically for the UK, which might be even more relevant for MSRA.
Oh, what are those?
So in the UK context provided, unexplained is slightly higher at 25%, ovulatory disorders also 25%, tubal damage 20%, male factors still around 30%, and then uterine or peritoneal disorders about 10%.
Similar categories, slightly different numbers.
Yeah, but the key message remains. And another crucial point they stress, around 40% of cases have contributing factors from both partners.
40%.
So it really underlines that need for joint investigation. They also mention other specific things like uterine issues, problems with the eggs or sperm themselves, gamete defects, embryo development issues, and endometriosis as contributors.
Okay, so building on those causes, are there specific things that make someone more likely to experience infertility? Risk factors?
Yes. The notes list the well-known ones. Advanced age is a major one affecting both egg quality and quantity in women and sperm quality in men over time.
Right, age is key.
Then there are lifestyle and health factors. Obesity, smoking, drinking too much alcohol. Also, specific medical conditions, PCOS, polycystic ovary syndrome is the example given because it directly messes with ovulation. And finally, exposure to certain environmental toxins.
And it's useful to think about those as, well, some you can change, some you can't.
Exactly. You've got your modifiable risk lifestyle, things like smoking, weight, alcohol, and non-modifiable ones like age. And understanding the why helps link it back. Obesity can disrupt hormones, smoking damages gametes. It connects back to those broader cause categories.
Okay, let's zoom in a bit. Biologically, what's actually going wrong? The pathophysiology.
So the notes list the core mechanisms. Things like problems with ovulation actually happening, issues with sperm production or their ability to function properly, blockages in the fallopian tubes preventing egg and sperm meeting or the embryo traveling, problems with the uterus itself, uterine abnormalities, general hormonal imbalances disrupting the cycle, and then, again, that category of unexplained causes where the mechanism isn't obvious.
And these link directly to the causes we talked about.
Pretty much, yeah. Ovulation issues are the how behind ovulation failure. Sperm problems are the how for male factor. Tubal blockage is the how for tubal damage. Understanding the mechanism helps pinpoint what needs fixing, if possible.
So if someone comes in saying they're struggling to conceive, what are the specific things we need to differentiate between? The notes call these differential diagnoses.
Right, and it's maybe a slightly confusing use of the term here. It's less about conditions that look like infertility and more about figuring out which specific underlying cause is responsible for the infertility in this particular couple.
Ah, I see. So distinguishing between the causes.
Exactly. The differentials listed are essentially those main cause categories again. Hormonal imbalances, structural abnormalities like issues with the uterus shape or blocked tubes, endometriosis, and male factor infertility. So the investigation process is about differentiating between these potential culprits.
Okay, that makes sense. So let's talk investigations. Someone presents, you've considered the possibilities. How do you actually figure out what's going on? The notes detail this pathway.
Yes, and the first point they hammer home is comprehensive evaluation of both partners. Given that 40% figure, you just can't skip that.
Absolutely. And when do you start these tests?
The standard guidance mentioned is after 1 year of regular, unprotected intercourse, and they define regular as every 2-3 days.
1 year, every 2-3 days. Got it.
However, and this is important, investigations can and often should be offered earlier if certain factors are present. Things like the woman being older, say over 36, where fertility declines faster, or if there's a known medical history suggesting a problem, like very irregular periods or previous pelvic surgery.
Right. Clinical judgment comes into play. So what are the first-line tests, the basics?
The notes highlight 2 crucial starting points. For the man, a semen analysis. For the woman, a serum progesterone level timed specifically 7 days before her expected next period.
7 days before.
Yes. And they helpfully clarify, for a typical 28-day cycle, that means testing on day 21. These are your absolute baseline checks.
Okay, let's focus on the woman's investigations first. That progesterone test. What's its main job?
Its specific purpose is to confirm ovulation. A decent level tells you that an egg was likely released that cycle. That's key information. The notes also say initial screening for chlamydia should be done for women.
Chlamydia, right. Any other tests for women?
Yes, depending on the situation. If periods are very irregular and long, progesterone might be checked again or at different times. Gonadotrophin levels, that's FSH and LH, might be measured, especially with irregular cycles, to check ovarian reserve or function. Thyroid tests, if there are any symptoms suggesting a thyroid problem, as that can affect fertility. And a prolactin levels if there are signs of an ovulatory disorder or rarely suspicion of a pituitary issue.
And how do we read those progesterone results? Are there specific numbers we need to know?
Yes, definitely nail these numbers for a revision. According to the notes, a level less than 16 nunmol, especially if it's consistently low, suggests ovulation isn't happening properly. Repeat the test, consider referral.
Okay, less than 16 is a red flag.
Then between 16 and 30 unmol, the advice is to repeat the test. Maybe the timing was slightly off or it's borderline. But the key one, a level greater than 30 unmol is generally taken as good evidence that ovulation did occur that cycle.
Over 30 confirms ovulation.
Yeah.
Less than 1630 repeat. Over 30. Okay, good. Now for the men.
The main test, the cornerstone, is the semen analysis, looking at sperm count, motility, shape, all that.
And what if that's abnormal?
The key guidance from the notes is about referral. If a man has 2 abnormal semen analysis results, you usually repeat it to confirm, then he should be referred to secondary care, to a specialist, fertility service, or urologist for a more detailed workup.
2 abnormal tests triggers referral.
Okay. And just like for women, screening for chlamydia is also recommended for men during the investigation.
Right. So once you've done the tests, got some results, or maybe even while waiting, what happens next? Management.
Yeah, management. The notes start with something really important: general care and advice. This isn't just about medical treatments, it's about providing support, reassurance, acknowledging the stress infertility investigations and the situation itself can put on couples.
That emotional side is
Well,
huge.
it really is. And interestingly, the notes mention some couples conceive naturally while waiting for treatment, maybe as stress reduces slightly, who knows. Fertility support groups and counseling are valuable resources mentioned. Then there's the practical advice. Women planning pregnancy should take folic acid. Couples should aim for regular intercourse every 2-3 days. Lifestyle stuff again. Avoid smoking, cut down excessive alcohol, maintain a healthy weight, BMI. They do also know there's limited evidence for alternative therapies like acupuncture, though some people try them.
So that baseline support and lifestyle advice is step one. When does referral to specialist services come in?
Referral decisions are based on the whole picture: age, medical history, and importantly, the investigation results. The general guideline mentioned is consider referral if no conception after 1 year of trying, but definitely consider it earlier after just 6 months if the woman is 36 or older.
6 months for 36 plus ration. Okay. And the actual treatments.
Yeah.
Medical, surgical, assisted conception.
Right. Medical options focus mainly on boosting ovulation. The notes name specific drugs: clomiphene citrate, which is an oral tablet, or injectable gonadotropins. These stimulate the ovaries more directly.
Okay, ovulation induction.
Then surgical treatments. These are for fixing physical problems. So surgery to unblock fallopian tubes or to treat endometriosis that might be distorting anatomy, or surgery for blockages in the male reproductive tract, like an epididymal blockage.
Fixing the plumbing, essentially.
Kind of, yeah. And then the big category: assisted conception techniques, or ART-T. The main ones listed are intrauterine insemination, IUI, where prepared sperm is placed directly into the uterus around ovulation time. Then, in vitro fertilization, IVF, eggs retrieved, fertilized with sperm in the lab, embryo develops, then transferred back to the uterus. And intracytoplasmic sperm injection, ICSI, which is a specific type of IVF where a single sperm is injected right into the egg, used for severe male factor issues. There are others too, like using donor eggs or sperm.
Any key details on IVF or ICSI we should flag?
For IVF, the notes highlight factors influencing success. Definitely age, BMI, and lifestyle factors play a big role. They also specifically mention the NICE's recommendation for single embryo transfer. So,
Oh, yes, to avoid multiples.
exactly.
Right.
Reduces the risks associated with twin or triplet pregnancies. For ICSI, its main use is stated as being for severe problems with the semen quality. Ejaculate due to a production problem, not a blockage.
Okay. And donor options.
Donor insemination, using donor sperm, is considered for azoospermia, other severe sperm issues where ICSI isn't suitable or successful, or if there's a high risk of passing on a genetic disorder from the male partner. Oocyte donation, using donor eggs, is an option for women with conditions like premature ovarian failure, certain genetic conditions affecting the ovaries, gonadal dysgenesis, or sometimes after multiple failed IVF cycles with their own eggs. But the overall message for management, stressed in the notes, is that it's highly individualized. The treatment path depends entirely on the identified cause or causes of infertility for that specific couple.
Right, tailored approach. So looking down the line, what's the prognosis generally? Likelihood of success?
The notes are realistic here. Prognosis varies a lot. It really depends on the underlying cause, the couple's ages, other health factors.
Makes sense.
But they do strike a positive note. They state that many couples can achieve successful pregnancies with the right medical help and support. Age and underlying medical conditions are flagged again as the major things influencing those outcomes.
Okay. And what about downsides? Complications? Either from the infertility itself or the treatments?
Well, for infertility itself, the main complications highlighted are the significant emotional, psychological, and social challenges. The strain on relationships, the stress, anxiety, depression. That's a heavy burden. Plus, any underlying medical condition causing the infertility might have its own complications or need separate treatment.
So, major psychosocial impact.
Definitely. Then for assisted conception treatments, the notes point to complications often linked to multiple pregnancies, which are more common with RT, although single embryo transfer helps reduce this. But the big one they flag is ovarian hyperstimulation syndrome, OHSS.
OHSS. Right, that sounds serious. What should we know about that?
It's a potential side effect of the hormone medications used to stimulate the ovaries, especially the injectables for IVF. The notes list typical symptoms: abdominal discomfort, feeling sick or actually vomiting, and abdominal bloating or distension. In severe cases, OHSS can cause serious fluid shifts, blood clots, kidney problems. It can require hospitalization. So clinics have strategies to try and predict who's at high risk and adjust protocols to minimize the chance of it happening, or manage it quickly if it does. It's a known, monitored risk.
Important to be aware of. Anything else on complications?
There's one more specific point mentioned about borderline ovarian tumors. The notes say that overall, the risk of long-term adverse outcomes from ART seems low, but there appears to be a small increased risk of these specific types of ovarian tumors.
Small risk, okay.
Yeah, and Nightsus recommends that women undergoing treatment should be informed about potential long-term health outcomes, including this small theoretical risk, just something to counsel patients about.
Right. Wow, okay. We've really covered the spectrum there, from the definition, the why, the how we investigate, the what we can do, right through to outcomes and risks. That's a lot of high-yield info pulled from those notes.
It is. It covers the core knowledge you'd need for this topic, definitely.
So, thinking about everything we've discussed, the fact that this affects 1 in 7 couples, the complexity of the causes, the investigations, the treatments, but also those really significant emotional and social challenges we just touched on. How might understanding all of that, the whole picture, shape how we think about supporting people going through this beyond just the clinical steps? That's a really important thought to leave things on. We've done this deep dive today, specifically pulling out that essential high-yield information on infertility from the MSRA notes, trying to structure it so it makes sense and sticks for your revision.
Absolutely. Going back over these points definition, the cause percentages, those progesterone levels, the main treatment types, OHSS symptoms, that repetition will help lock it in.
And if you are revising and looking for more top-notch resources, do check out passthemsra.com.
Yeah, and don't forget you can access completely free revision materials over at freemsra.com.
Until our next deep dive, keep learning.